Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Rhiannon Ashman, the Deputy Editor of MIMS Learning, and I'm really pleased to be here today with our editor, Pat.
Hi Rhiannon, great to be here.
So today we're talking about perinatal mental health, which is a subject that often carries a heavy emotional weight for patients and can require GPs to act quickly in finding appropriate support for patients as well. So Pat, can we start by defining what we mean by perinatal so that we're all on the same page?
Sure, so we're referring to the period starting from the beginning of pregnancy through birth and up till the baby's first birthday. It's a significant window of time where a woman's life can change fundamentally, and most of these changes are positive, of course, but some people find this to be a challenging time.
Absolutely, and to put this topic in a bit more context, you'll be aware of the government-commissioned review by Baroness Amos, which reported in February about systemic failings in maternity care. And following this, the government's just set up a new maternity and neonatal task force to take on the recommendations. And of course, there are so many great examples of care, but keeping this context in mind, I think it does highlight what a vulnerable time the perinatal period can be and what a difference healthcare professionals can make.
Yeah, I agree. And to add to that, I really enjoyed your interview a few weeks ago about breastfeeding and medication. And that reminded me just how important those first months and years of a child's life are for bonding between mothers and babies and the development of secure attachments. So this just underlines the potentially long-lasting ramifications of mental health problems during this crucial window.
Thanks, Pat. I'm glad you enjoyed that. And by the way, I'll link that episode in the show notes along with the learning modules that we're going to mention today. So let's start by looking at just how common mental health conditions are. In a talk at MIMS Learning Live North, Professor Carolyn Chew-Graham, who's a GP and Honorary Professor of Primary Care Mental Health, referenced some research showing that perinatal mental health disorders affect up to 25% of women. And she added that 90% of these women are managed within primary care. So that might be by GPs as well as the broader team, including health visitors and NHS talking therapies, for example.
What sort of mental health conditions are we talking about here?
Well, the whole gamut of conditions that can affect non-pregnant people can also obviously apply in this population. But in terms of what primary care are likely to see and what we'll be talking about today, it's depression, anxiety, PTSD that are the most common. And GPs may also see perinatal women with OCD, eating disorders, and possibly also postpartum psychosis, which, while it's not common, it affects between 1 in 500 and 1 in 1,000 women. Professor Chew-Graham says that GPs will probably all come across somebody experiencing this during their careers, so it's definitely worth being alert to.
And of course, sadly, the worst possible outcome of mental health problems in this group is maternal suicide. And we know from the Embrace UK reports that suicide remains one of the leading causes of death for women during the perinatal period. And if we look at the period between 6 weeks and a year after the end of pregnancy, mental health conditions account for nearly 40% of maternal deaths. And we mustn't forget that Black women are almost 3 times more likely to die than white women. Asian women are almost twice as likely to die than white women, and women living in the 20% most deprived areas have the highest maternal mortality rates, more than twice as high as the maternal mortality rate of women living in the 20% least deprived areas.
Yeah, these are staggering figures, and the learning module that we've got on our website setting out the lessons that can be learned from the Embrace reports was one of the most sobering ones that I've worked on. So in this episode, we'll be holding all of this in mind alongside the stresses and time pressures of modern primary care, while also hopefully equipping you with some more tools to understand and manage the complexities of mental health during the perinatal period.
So, Rhiannon, if I'm a GP looking at my afternoon list and there's a pregnant or recently postpartum woman coming in, what should I be looking for?
So in her conference presentation, Professor Chew-Graham suggests using the biopsychosocial model to frame thinking about risk. And that is firstly looking at biological factors. So that might include previous pregnancy loss, which can, of course, make a subsequent pregnancy an incredibly anxious time. And then there's any history of mental health problems. So if a woman has struggled with depression or anxiety before, the risk of perinatal relapse is significantly higher. And to add to this, the Embrace reports noted that some 37% of the total number of women who died during the inquiry period were known to have pre-existing mental health problems. Physical complications such as preeclampsia or gestational diabetes shouldn't be overlooked because these are risk factors for anxiety and depression also. So they're the biological factors, and the psychological factors might include different coping styles or personality traits. And then there are social factors as well, which are possibly the most complex.
Yes, so these would include things like substance misuse, criminal justice involvement or social services involvement, homelessness, immigration status, adverse childhood experiences, and domestic abuse. And the Embrace report noted that of the women who died during or up to a year after pregnancy in the UK during the time frame that it was looking at, which was 2019 to 21, 12% were at severe and multiple disadvantage.
Yeah, you mentioned domestic abuse then, Pat, and the Embrace report pointed out that this was an area where improvements could be made insofar as identifying and recording this information. So although it's recommended that healthcare professionals ask about domestic abuse at each woman's booking appointment and throughout the pregnancy, the inquiry found that around 30% of women's records didn't include this information.
Yeah, I think that's really important. And the NICE clinical guidelines on pregnancy and complex social factors are clear here as well, that healthcare professionals should be having these discussions in a non-judgmental way, and specifically should offer a one-to-one consultation without family members or partners present on at least one occasion.
Yeah, it's important to remember, though, that the authors of the Embrace report say a single conversation is rarely enough. So ideally, professionals will build a continuous dialogue with patients at every point of contact.
Dr. Carrie Ladd, who's a GP and former Royal College of GPs perinatal mental health champion, has written a module for us on perinatal mental health disorders, and she makes a good suggestion that professionals can ask, how are you finding being pregnant? Is it what you expected? Or how are you finding being a mum? Is that what you expected? And she says you should consider the response and note if there's hesitation before someone answers. They may be reluctant to disclose for reasons of stigma, shame, guilt, or fear of consequences, for example, from social services.
Yeah, this is a really good point. And it's something that Professor Chu Graham also commented on in her presentation, that women may not answer screening questions truthfully because, as you said, fear of judgment or fear that their baby may be taken away.
Yeah, and that's a significant barrier, and stigma is still so prevalent. But Professor Chu Graham echoed what Dr. Ladd said, in that this is where clinical intuition comes in, which we know GPs are really skilled at.
Yeah, so to aid that intuition, what are the screening tools that can be used in a time-limited consultation?
Well, the NICE guideline on antenatal and postnatal mental health indicates that case finding is important at booking visits. So that would likely be done by midwives, but NICE also talks about case finding for anxiety and depression in routine appointments, whether that's antenatal appointments or whether that's opportunistically.
So for depression, there's the questions. During the past month, have you often been bothered by feeling down, depressed, or hopeless? And secondly, during the past month, have you often been bothered by having little interest or pleasure in doing things? And those questions would apply to anybody, not just perinatal women. But if a woman responds positively to these questions, then you would move on to tools like the PHQ-9. Some areas use the Edinburgh Postnatal Depression Scale, but Professor Chu Graham mentions in her conference presentation that the PHQ-9 may be becoming more standard in many areas now.
I hear from our GP advisor that depression and anxiety often co-present. So what about assessing for anxiety?
So Professor Chu Graham observed that perinatal anxiety is thought to be experienced by 21% of women. And for this, there's the 2-item Generalised Anxiety Disorder Scale, GAD-2. And that is, number 1, over the last 2 weeks, how often have you been bothered by feeling nervous, anxious, or on edge? And number 2, over the last 2 weeks, how often have you been bothered by not being able to stop or control worrying? And if a woman scores over 3 on the GAD scale, you might consider doing a more in-depth GAD-7 or referring.
I believe in May last year, NICE considered lowering the cut-off score from 3 to 2 on the GAD score, but decided against doing so at that time. But nonetheless, I guess the clinical acumen comes in again here. And if a woman scores less than 3, but you're still concerned, NICE recommends asking follow-up questions, doing the GAD-7 or referring.
So returning to depression, Dr. Ladd says in her module that even though healthcare professionals are much more aware now of postnatal depression, many patients don't realise that it can be a significant and potentially life-threatening medical condition, and that it's different from the baby blues, which is a common temporary emotional lability related to postnatal hormone shifts that can settle within a few weeks of giving birth. So taking these misconceptions further, Dr. Ladd says that many women think that symptoms of postnatal depression are par for the course for new mums, and she emphasises that while most new parents will have difficult days, the key difference is that women who meet the criteria for postnatal depression will experience these symptoms all day, every day, all week, every week.
Dr. Ladd also makes a good point that as well as postnatal depression, women may experience antenatal depression, but this is less often picked up.
Yeah, so speaking of less commonly noted conditions, we've thought about generalised anxiety, but anxiety disorders may present as OCD or PTSD. for example. So should we talk a bit more about these?
Yeah. Dr. Ladd says perinatal OCD is not a condition that most healthcare professionals consider, but it is extremely important to identify. She gives a useful tip in her module that one physical sign to look out for is contact dermatitis on the hands. That can be a clue that a mother is performing obsessive hand-washing rituals.
And the intrusive thoughts in OCD can be terrifying. For mothers, they might have unwanted images of harming their baby, of dropping them, or maybe they're too scared to fall asleep in case they roll over and squash their baby.
So that's a good example of where healthcare professionals can offer kindness, empathy and reassurance that women will feel better with treatment, which we'll come back to later.
Yeah, so moving on to the topic of PTSD in this group of patients, this is often a result of trauma from a previous birth, and it's more widespread than you might think, isn't it, Pat?
Yeah, it is. So between 4 and 5% of women, that's roughly 30,000 women a year in the UK, develop PTSD after giving birth. And Dr. Kim Thomas, the CEO of the Birth Trauma Association, wrote a fascinating piece for us on how to provide trauma-informed maternity care, in which she says that this is based on a recognition that pregnancy and birth can reawaken memories of previous trauma to the extent that trauma symptoms emerge again.
Absolutely. And she adds that women who've survived sexual abuse are 12 times more likely to experience birth as a traumatic event than those who've not. And for these women, elements of the birth experience can bring back vivid memories of the abuse. So it's absolutely worth being aware of in primary care. But offering trauma-informed care to a pregnant woman requires her first to disclose her traumatic experience, and many will be reluctant to do so for the same reasons as we've discussed earlier around screening for anxiety and depression. So this can make diagnosis tricky.
And in her module, Dr. Ladd says that PTSD is often misdiagnosed as postnatal depression, but the symptoms are different. So they may include hypervigilance, flashbacks, and feeling on edge all the time. And if you treat PTSD with just antidepressants, they often won't work, she says. Women need specialised trauma therapy, such as eye movement desensitization and reprocessing, or EMDR.
So we've considered anxiety disorders, including OCD and PTSD, as well as depression. But the NICE guidelines also mention eating disorders, saying that changes to body shape, including weight gain in pregnancy and after birth, can be challenging for women with a history of eating disorders. Although apparently the prevalence of anorexia and bulimia is lower in pregnant women, while the prevalence of binge eating disorder is higher.
So what are the options for women with eating disorders or a history of eating disorders?
So they should be offered psychological interventions in line with the NICE guidelines on eating disorders, and they would need to be monitored carefully to assess the need for fetal growth scans. Should we also talk about postpartum psychosis now?
Yeah, sure. So while this is rare, it is a psychiatric emergency and often develops quickly, usually in the first few days or weeks after birth.
Yeah, and it's worth noting that NICE say that if a woman has any past or present severe mental illness, or if there's a family history of severe perinatal mental illness in a first-degree relative, professionals should be alert for possible symptoms of postpartum psychosis in the first 2 weeks after birth.
So what symptoms should healthcare professionals be looking for?
Well, Dr. Ladd outlines some of these in her module, and they include elation, delusions, hallucinations, as well as rapid or incoherent speech or conversations. And she says women might also stop eating and sleeping.
And as mentioned, suspected psychosis is an emergency, so it warrants immediate referral to the specialist perinatal psychiatry team within 4 hours. NICE says the woman should not be left unsupervised with her baby, and Professor Chu Graham advises becoming familiar with your local pathway, whether it's the crisis team or a specific perinatal service.
So while we're on this topic, would it be worth reviewing the red flags to look out for in a perinatal woman? So Dr. Ladd's module lists a recent significant change in mental state or emergence of new symptoms as being a red flag, as well as new thoughts or acts of self-harm, and new or persistent expressions of incompetency as a mother or estrangement from the baby as requiring urgent escalation to psychiatry.
Thanks. So let's move on to management. If a woman was diagnosed with perinatal depression or anxiety, what are the GP's options?
So according to NICE, psychological therapy should be the first line treatment, and it's recommended that this is started within 6 weeks of a referral. Depending on the severity of symptoms, a woman might use facilitated self-help or might be referred for high-intensity psychological intervention, for example, CBT. And Dr. Chu Graham says that in most areas of the UK, perinatal women would be prioritised for NHS talking therapies.
Oh, that's good to hear. And what about medication? As you discussed in your podcast episode a few weeks ago, there is so much anxiety, both for the patient and sometimes for the GP, about prescribing in pregnancy and in breastfeeding women.
There is, yeah. And there are obviously a lot of considerations around prescribing in pregnancy and breastfeeding. And the NICE guidelines go into this in detail in the section on starting, using and stopping treatment. for mental health disorders. But essentially, you're dealing with a different risk-benefit profile than you would be if a patient were not pregnant or breastfeeding. And while there are risks of medication to the baby during pregnancy and breastfeeding, these do have to be balanced against the notable risks of untreated mental illness in the mother.
Absolutely. And NICE says the lowest effective dose should be used. This is particularly important when the risks of adverse effects to the woman, fetus and baby may be dose-related. But I thought it was interesting that they also specifically point out that subtherapeutic doses may also expose the fetus to risk and not treat the mental health problem effectively. And as we know, untreated depression can lead to things like poor self-care, substance misuse and disrupted bonding, which has long-term consequences for the child's development.
Yeah, a key point that I took away from my interview with the pharmacist Rachel Pilgrim that we mentioned about medication use while breastfeeding specifically is that in most cases it shouldn't be a barrier to continued breastfeeding, which has such well-documented benefits for mothers and babies. And while trial evidence is understandably thin on the ground for drug safety in pregnancy and breastfeeding, Rachel told me that we do actually have access to a lot of pharmacokinetic studies, post-marketing data, showing that many drugs are likely safe in breastfeeding. And there are plenty of reference sources that collate this information, which she goes into in more depth in the podcast episode. So how about more complex or severe mental illness?
Well, in those cases, GPs should always involve the specialist perinatal team for preconception counselling or management during pregnancy or postpartum.
And returning then to less severe mental illness, should we also mention some general principles and lifestyle changes that can be useful for GPs to discuss with patients?
Yes, and it sounds a bit basic, but encouraging a regular meal schedule, hydration and gentle aerobic exercise can really help. Dr. Ladd mentions buggy fit classes, which have an added benefit of social connection with other parents, and additionally support from friends, family and local parent groups alongside the wider primary care team is essential in helping people through illness during this time.
Well, Pat, we've covered an incredible amount of ground today, and as we've gone into this, I've realised just what a vast topic perinatal mental health is, and with so much complexity around the impact that these conditions can have on mothers and on children.
It truly is, and importantly though, as Professor Chu Graham said, early diagnosis and adequate treatment can really make a difference to the mother and baby, and it's a chance to change the trajectory of two lives.
Before we wrap up for today, we'll run through some key learning points. Up to 25% of women experience perinatal mental health disorders, and 90% of these cases are managed in primary care. The biopsychosocial model can be used for considering a woman's risk, and it includes history of mental illness, physical complications, and social factors such as homelessness, immigration status, and domestic abuse. While screening tools for anxiety and depression are useful, women may be reluctant to disclose that they're struggling. Clinical intuition is really important here, and kindness, empathy, and reassurance from healthcare professionals can help women to open up. Postpartum psychosis is a psychiatric emergency requiring immediate referral to the specialist perinatal psychiatry team within 4 hours. Along with signs of psychosis, red flags can include significant change in mental state or emergence of new symptoms, new thoughts or acts of self-harm, and new and persistent expressions of incompetency as a mother or estrangement from the baby. Well, that's it for today. Thank you very much, Pat, and thank you to you for listening. You can find all of the resources we've discussed today linked in the show notes. And don't forget that you can claim CPD credits for listening to this podcast. Just head to mimslearning.co.uk to download your certificate. We've been the MIMS Learning editorial team, and this episode was produced by Jude Owen. We'll see you next time.